Welcome, a warm welcome to you indeed. Roy Noble here, and it's a great privilege to be here as a Bevan Commissioner on an auspicious occasion. Croeso cynnes i chi gyd ar ddwrnod ni wedi casglu at ein gilydd nawr am rhywbeth arbennig I rannu gyda'n gilydd. The Showcase for the Adopt and Spread program. We're supporting adoption sites as they take Bevan exemplar innovation right across Wales. I've always been intrigued with where that talent comes from. Is it innate? Are some nations better at it than others? I wondered. For instance, somebody tried to analyze the Welsh once. It was a Welshman. And he said, to measure a Welshman, you have to measure him from the neck up for a start. And Welshmen are intelligent, intellectual, and they are emotional, educated, excitable. They are cultural, they are caring, they are charismatic, vigorous, and vibrant. If they could only be if they could only be humble, they would crack it, couldn't they? Mine was the same with the British. It's a mixture because every nation is a quilt of patches, and the British are the same. What is a British person or an English person? Well, it's a person who jumps in a German car on the way home. He has a Turkish kebab or an Indian takeaway, sits on a Swedish settee, and watches an American film on a Japanese television set. So it is spread internationally. So if you are in Wales working on these and you are Welsh, fine. If you're not Welsh, but you're in Wales, that's enough. That qualifies you to have the stamp of Wales upon you and to fly our flag, all right? So then, the Bevan exemplars have been leading the National Adopt and Spread program across Wales over the last 18 months, building on the work over the last 5 years with the Bevan exemplar innovators themselves. Now, 15 of the Bevan exemplar innovators were selected to share their innovations with a new site. Over 50 new adoption sites have taken on one of these great innovations, and over 150 people have been involved in the adoption and spread of innovative ideas and innovations across Wales. Now, this work, don't forget, has taken place during COVID-19, and the participants have had to work exceptionally hard to make an impact and to ensure that we learn from the program. There is a panel of project members here with us, and they're very welcome indeed. Participated, they did, of course, in the Adopt and Spread program, and they with guests. Now, they will be ready to answer questions, the participators. So put your questions in the chat box, and the host will make sure that your question is asked and then answered, indeed. So our thanks indeed to the exemplar innovators, because I remember Julius Caesar when he supposed to have jumped off his boat and he fell, but then he got up and he said, Veni, vidi, vici. I came, I saw, and I conquered it. Perhaps these days it should be Veni, vidi, Velcro. I came, I saw, and I stuck to it. Or even better still, Veni, vidi, visa. I came, I saw, and I got a grant for it as well. Who knows? So today, enjoy yourself, be interested, be enthralled, and be inspired. It's lovely to have your company. Diolch yn fawr iawn.
Welcome to the Bevan Commission's Adopt and Spread Showcase event. We're really pleased that you're here today to listen to our feedback and to listen through the learning that we've acquired over the last 18 months. We all know that ideas alone are not enough. They don't necessarily get adopted and spread by others, even though we think they're great ideas. And so the Bevan Commission has been really exploring this in further depths during the last 18 months or so. We've worked with 13 exemplar projects, over 50 adoption sites, and over 150 people during the last 12 months. I hasten to add, which has probably been the most difficult, treacherous, and traumatic 18 months that we've all seen. Notwithstanding that, we have seen some amazing outcomes and amazing people and who have shown their commitment and great, I guess, a great opportunity to understand what makes things work. This event today will provide further details on what helps and hinders that adoption and spread. We've got tools, we've got other support that will be part of this whole program, but it's essential that we now learn more about this in order that we can move on, not only from COVID, but move on into the future and make sure that we continue to innovate and change as we do. I'm going to hand you over to your host for today, But in the meantime, make sure you tweet, make sure you enjoy the session, and overall, make sure you make that real difference.
Well, hello, everybody, and thank you so much for joining us today at this showcase event. We're going to be looking at a very special project, 6 Steps to Success, supporting palliative and end-of-life care. So we're very grateful so many of you have been able to join us. Essentially, us getting together to learn about and to think about and to hopefully share these ideas is what Adopt and Spread is all about. And we really hope you'll take something away from today that will inspire and motivate you to innovate, but also to learn from others who are doing so. My name is David Pritchard. I'm the Director of Regulation at Social Care Wales. For those of you who are not aware of Social Care Wales, it's a Wales-wide body that undertakes the regulation of the social care workforce. It also leads on developing that workforce, on research, on data, and on service improvement. And we are very much supporters of the work of the Bevan Commission, and we're very much delighted and privileged to be asked to host this session today. We do believe, I think, in Social Care Wales, that the approach of exemplar projects and then using those to adopt and spread is going to be a really meaningful change mechanism for Wales health and social care. Today, we're looking at a particular project, and as we go through today's session, we'll be having a couple of short videos, but perhaps more importantly, some time to talk to those who have really driven this particular project, driven the innovation that it represents. And all of you will be aware that innovation isn't a genius sitting in a garage coming up with a light bulb moment. It involves collaboration, working together, sharing ideas, refining ideas, being critical friends, challenging and emerging with something that can actually make a meaningful impact on people's lives. And I think today you're going to see that kind of collaboration, that kind of teamwork exemplified by this particular project. I'm going to introduce you to the chat. Well, I'm going to ask the panel themselves to introduce themselves, the people who have been doing the work on this project. We're going to take a short video, and then we're going to open up to some questions. We've already had questions for us to be asking, but we hope to get towards the end an opportunity to ask those that emerge during the day. Okay, I'm going to ask those 5 members of the team to say who they are and where they're from, and then we'll watch the video. So, Teresa, would you like to start and say hello?
Hi, everybody. I'm Teresa Richards. I'm the Bevan Exemplar for this project. I was a Bevan Exemplar in 2015. I was Macmillan Lead End-of-Life Care Nurse Facilitator for BCUHB, but I've recently now retired. Tracy?
So, Tracy Evans, I'm a trainer and assessor for Wrexham County Borough Council, and adopted a domiciliary care 6 Steps to Success programme for the Wrexham area, working in partnership with BCU, HB and Teresa. Sarah?
Hi, I'm Sarah Wheeler, lead nurse for end-of-life care planning, Macmillan lead nurse, and that's in Powys Teaching Health Board.
Lisa?
Hello, I'm Lisa Waller. I'm the Macmillan End-of-Life Care Modernisation Manager based in palliative care here in Cwm Taf Morgannwg Health Board. Jules?
I'm one of the palliative clinical nurse specialists working out of Cwm Taf Morgannwg. I was asked, would I be part of the 6 Steps programme along with Lisa in this innovative programme to start looking at delivering the teaching programme to nursing homes within our borough.
Thank you. So that's the team, and we'll be hearing more from them as we go on. Look, what I would say is, goodness me, if anyone ever says to you, you can't do innovation, just imagine what we've done in the last 14 months. Who'd have thought we'd have been sitting here in this way, doing this kind of meeting in this way? And you know, it's not the ideal way, perhaps in some ways, but it means that all of us can be in the same meeting, listening to the same stuff, and hopefully the ideas can be spread even beyond. So grateful for the panel for introducing themselves. We're now going to play a short video, and then we're going to come back and ask some really hard-hitting questions of the people you've just heard.
We wanted to provide a quality of end-of-life care training across North Wales to nursing homes. We wanted to drive up the standard of end-of-life care available to residents in nursing homes, and we wanted to reduce the unscheduled admissions into the acute sector. Our audit results show that 82% of residents and individuals have achieved their preferred place of care, and one patient said to me, "I feel I have a voice now."
To me, dignity means it can be from like a minor thing, shutting the door behind you when you go into a room. I'm now a dignity champion. I've got other colleagues on board that are champions as well, and that includes domestic staff as well.
The biggest difference that I've experienced is the knowledge and confidence that I've taken on board. I can now share out to the staff and other seniors, family members as well, and I feel more confident in talking about end-of-life care.
Hi everybody, I'm Teresa Richards and I lead the 6 Steps programme for Betsy Cadwaladr University Health Board. Our data now is that we have had 66 nursing homes, 45 residential homes, 4 assisted living and 2 domiciliary care agencies that have gone through our programme in BCUHB. It's had some very good results. Mainly really avoiding unscheduled admissions for residents from care home settings and also other settings. So we're absolutely delighted that this has taken off in our local area, but even more so that we are now part of the Adopt and Spread programme. I think adoption and spread is vital. I think when you have an innovation which you feel is good practice, it's shown to be it's shown to have a really good clinical governance structure, and it's shown to make a huge difference to people, particularly in Wales. I think it's really important that we spread this. So as part of the Adopt and Spread programme, the 6 Steps to Success education programme has now gone into 3 areas in Wales. One area is Cwm Taff Health Board. The other is Powys Health Board, and obviously it's gone into domiciliary care via Wrexham County Council. And I think it's really important that we're looking at different care areas to spread this 6 Steps programme. So hopefully other health boards will take notice of this and will come forward, and maybe in the future we can spread this more widely across Wales.
So thank you for that, and hopefully that will give some sense of introduction. But I think the real understanding of the kind of behaviours, the kind of way of working, the approach is going to come through some of the questions that we've got in front of us that I'm going to kind of facilitate today. And what I'm going to do, just to warn the panelists, I am going to suggest a panel member to answer a question. But if other members of the panel do want to come in afterwards, then that's fine, and just do so. But Teresa, I did want to perhaps start by asking you, as an exemplar project, why did you start this work, and why do you think it's an important innovation?
I looked at at the Six Steps to Success Palliative Education programme in probably around 2013, really. And we commenced it into BCUHB because it was a programme that was robust. It had a good clinical governance system underpinning the programme. It ensured quality and safety for individuals and families in different care settings. And it fitted really well with the vision I had for taking an education programme forward into care homes. We've led the programme across North Wales, and obviously I'd said I became a Bevan exemplar in 2015. Which was great because they're very supportive with the programme. And recently we've adapted this programme, the Six Steps programme, with permission to reflect the CIW key themes and regulations. And we are now on the website, the national website for Six Steps, with a link to Six Steps Wales, which is something in BCUHB we are extremely proud of. Yeah, it's important because it provides a cost-effective and efficient method, I think, of disseminating best practice. And because it's equitable, it really fitted well because the same programme is given to the care settings, but it's also flexible, and that's why it was very useful to take it forward for Adopt and Spread.
Thanks, Teresa. Just to kind of build on that, I suppose, you obviously, part of the process of Adopt and Spread is to find adoption sites, people who can kind of take on the innovation and build on it and build into it. And so how did you introduce those sites to this innovation, this way of working, and how did you support them when you did that?
Yeah, it was always a sort of a dream of mine that this could be spread further across Wales. So when the Adopt and Spread programme commenced, I was very keen to be part of that, and luckily we were. So yeah, it's really important, isn't it, that you clearly define the programme that you have when you're explaining it to other sites. So it was very much important that I took time to speak to the sites, to introduce the Six Steps programme, to give them support. It's important that they felt confident taking this programme forward. I looked at, I did visit them, and this was just before, obviously, we've had the COVID. I was able to visit them. I was able to go and do some study days with the sites. I was able to do some teaching. I was able to follow that up with some emails, with some telephone calls. Gave them lots of information and encouraged them to ask questions. Really important to look at exchanging different viewpoints, I think, when you're spreading a new innovation, because you feel really strongly about your project, but it's important to listen to others and listen to what viewpoints they have. We did a lot of reflection. And, you know, there was expectation to me that, you know, things would be variable, that when they take this forward, it is open to a flexible programme. So I knew that would happen, and that was fine. But I think the main thing for me was that we worked together, and that we all felt really strongly about the programme and what the outcomes of this programme are, and what we wanted to achieve in the different care settings that this programme was taken into.
Thanks, Teresa. I have a confession to you all. It's not really a conflict of interest, but I do originally come from Wrexham. Yes, I know. I spent all my childhood in Wrexham, and people often say to me, you know, what good has ever come out of Wrexham? And I start with Mickey Thomas, and then I go to Wrexham Lager. Well, now I'm going to be able to add this programme as an example. So Tracy, I'm going to come to you, if I may, because you know I recognize. Look, I work in the social care sector. and I kind of recognise that a lot of this has been crossing over, but how flexible is this programme? If you think about other kind of environments, other services, other care home environments, etc., is it going to work in that way, do you think?
Deal. Thank you, David. Yeah, absolutely. It's I think our adoption and spread programme has clearly shown that, you know, we've all done different areas of sectors within social care. So, for instance, I've done domiciliary care, Sarah has done residential setting, and Julia and Lisa have done nursing homes. And as Teresa alluded to, we've also done supported living and sheltered accommodation. But I think the important thing of it is the partnership working you have. So BCU have brought their expertise in their clinical skills and their expertise and experience around palliative and end-of-life care. And obviously Wrexham County Borough Council, we've brought the expertise of the knowledge of the sector, the knowledge of the way the sector works, the knowledge of the legislation around the sector. And so within the programme, we also bring other experts in. So things, consultants in specific areas like motor neuron or chest and lung conditions, occupational therapists, the palliative care team, so the experts in the nurses, pharmacist, dietitian. We work closely with the hospice and the hospice at home team, funeral directors and clergy, and by bringing all that flexibility of the partnership working helps to ensure that the programme is flexible to the individuals, ensuring they get the breadth of knowledge they need to support the individuals. And at the end of the day, the sector is supporting individuals at end of life. So that doesn't mean whether you're in domiciliary care, residential, there's still that individual.
Thank you, Tracy. I mentioned earlier the pandemic. You may have noticed we've been in one. It's been quite a challenging period, hasn't it? For many, many reasons. And you know, some of what we've learned during the period is how actually some types of innovation we can do really, if we just have a mind to it and you have to do things, sometimes things are actually are possible. And you know, having worked with the Welsh Government for many years, it's been quite amazing to see how quickly decisions have been able to be taken, etc., etc. So that's been great. But goodness me, doing a project like this about end-of-life care and palliative care during COVID, I cannot imagine the challenges that would cause, you know, and I don't need to go into the details, but Lisa, I wonder how the restrictions of the pandemic affected the ability and how you delivered this particular project and programme.
Okay, so the programme itself consists, the format is for 8 face-to-face workshops where we'd expect the representatives from the care homes to come in and we deliver face-to-face teaching. Obviously, with the pandemic occurring, we had to rethink this option. So during the start of the pandemic, the pilot sites were all at different steps of the course. Some had already held face-to-face workshops, were already somewhat through. We in CUMTAF were at the stage where we were hosting our engagement event, and we'd invited our care homes within our area to attend. And we'd arranged a follow-up training session with Teresa to come down to us to visit with we'd be taking on new team members. So when the national lockdown happened, we had to rethink our strategy there and what we were going to do. We had to cancel our engagement event and then sit back and decide how we're going to proceed. You know, we weren't sure how this was going to pan out, given that our target audience is indeed care homes, who were the ones that were greatly affected, I think. So we had a few crackly telephone calls in those early days between us. A lot of feeling about, this is where the virtual contact kind of started off, with who's talking first and everyone trying to you know, put their ideas across. And we discussed how we could possibly offer this virtually. And this actually formed part of the learning, how we were actually going to deliver this. We were learning as we were going along, and then being able to instill that in others. So as the pandemic progressed, we realised the project was definitely going to be affected. For us in CTM, Julia and a few of our trainers, because we had a team approach for ours, are all CNS nurses that were all asked to go and work in different areas of the health board during the pandemic, inoculations and that kind of thing. So we had to take a step back. From the care home perspective, they obviously closed their doors. They weren't allowing visitors, and a lot of the homes weren't allowing their staff to come and see us either. So part of the course is to go into the homes to monitor progress, how they're getting along, are they actually implementing the changes that they're planning to make to improve and build on the good care they already give, so to enable us to sign off the programme at the end. So we discussed this in the background, how we're going to deliver this remotely. The organisations themselves, one of the not a barrier, but something we had to come over was the different platforms available for us to use. We were lucky in Cwmtaf that we'd just started being given MS Teams to use. I've got a background in IT, so very lucky for me that I could actually get on with it. I know Tracy had another platform to use. For us to communicate together, that obviously caused a challenge because we had to find a way of maintaining contact as we went along and how we were going to look at this. So we decided we were going to progress with the course. We looked at the content and how we could deliver this in a remote way. And we in Cwmtaf re-engaged with the homes that had shown interest, and they were all quite keen to continue despite what may or may not have been going on in the background. So in September, we contacted them and we did a trainer needs analysis to them. Nothing to do with the course itself, to make sure that they were IT competent, that they could get online, they could answer emails, they had the right kit, Wi-Fi, things like that. We had a quick session and it worked, everything went fine, we were all happy, they were happy, we went. Sent out all our invitations to our sessions and we were good to go. When we started, this then took us into what was then becoming the autumn peak, and things were starting to rise, and then the care homes were hit again. And we found then that we did have a few care homes withdrew, not surprisingly, due to pressures in the home. Particularly some of our homes had staffing issues, illnesses within the team, and one particular had a bereavement themselves from COVID. So this all affected the attendance for the courses. So part of the governance for the course is good attendance. So where we could, we supported them by offering a catch-up session. We recorded the sessions that we were delivering, so we could send them to the homes as well to reinforce the learning. And we changed how before we would signpost to learning, where we could, we directly gave them that over via email or however we could. So we got through it, and we're very pleased to see that the homes got through it. It was very much a learning curve for us. I think the positive point to raise is, whereas we would have kept in contact, I honestly think working this way has made us stay in contact more. We've had more opportunity to do things like this, virtual meetings at a drop of a hat. We've stayed in contact with emails. We've just looked outside the box, I think, with the programme. It is a face-to-face programme, you know, and lots of elements would benefit from that, as a lot of the course is group discussion, but we found ways around that. Now restrictions are easing. We're allowed to go out to the homes now to finalise things, to look at their portfolios in an outdoor space. So it was just tying things up and being aware of what was going on at the time and adapting as we need to.
Thanks, Lisa. That's really helpful. I mean, a lot of what you say will be kind of familiar with people, I suspect. You've had to adapt and adjust, but as I say, given the nature of this work, it is really impressive to kind of still be in the pandemic, but be able to report on the progress and success you've had. And Sarah, I'm going to come to you next. I've got a question here asking about measures for success. So I suppose, you know, what does good look like? What's the impact you're having, and how you can improve those measures? So do you have any kind of views on how you could improve those and whether the project is doing that?
Yeah, thank you, David. Just to say that there's a really good Six Steps website, and that's run by the National Six Steps to Success team. So I think Lynn Partington's on the line as we speak. So there's amazing resources on there, and part of those resources are that there's comprehensive measures that we utilise, which are really helpful for the care homes or the domiciliary care services to actually identify their improvements and the implementation of their improvements. So it starts off with knowledge, skills and confidence audits. So it looks at 16 key quality improvement areas, and that's a comparative audit. So they look at it pre and post programme, and they can actually utilise that then for all their other staff to actually feed into training needs, and training needs matrices really. So and just to say that these are ongoing. So and this programme is what we want for Wales is a sustainable programme that creates that coordinated and equitable care for everybody at end of life. So you've got the sort of qualitative measures as far as the individuals and improving their skills and competence, and then there's an organisational audit, which sort of reflects national quality markers. So things like the end of life delivery plan, the lines of inquiry as far as the care inspector at Wales. It also looks at it reflects the sort of NICE guidelines and the care decisions for last days of life. So it really reflects all these important national key markers really to improve services. So, and when we think about sort of key markers, it's looking at sort of coordinated care, good communication, good sensitive communication, reducing unscheduled admissions, achieving preferred place of care, preferred place of death, bereavement support, and it looks at the legal frameworks as well around Mental Capacity Act. So it's making sure that the staff are all competent in that area. So it's giving that skilled workforce. But obviously, there's a lot of qualitative measures, improvement measures, and there's a lot of quantitative measures as well that we can extrapolate from the figures, and especially, in that important aspect of achieving that preferred place of death and reducing, Teresa, and we've all got evidence to show we've reduced unscheduled admissions at end of life, and that is a really important marker. But as far as measures are concerned, we do want to start to look at improving user involvement, really, so that we look at more around the relatives' experience, the residents' experience, the staff experience, and that sort of care of all those three main important parts of the care home. But I'm still sort of grappling with how we really improve those aspects of care that really matter. So, for example, when we think about, I had a member of staff that reported that because of her improved knowledge, skills and confidence, she was able to articulate the needs of her resident, who was obviously deteriorating to end of life, and despite pressure from other forces, was able to keep that resident in the residential care home, and that was really important for the gentleman involved, really important for their family, and really important for the staff as well, because they're one big family. So it's how we extrapolate, that those quality elements that really make that difference, really matter to the individual, that kindness and compassion. And that's what we've got to improve on, is to really bring out those stories, you know, that meaningful care, thinking about memorials as well, and bereavement support. Gosh, we've had lovely examples, all of us, of relatives really valuing the fact that they could come back to the care home, and there was one where there was a memorial tree, and they could just acknowledge their loved ones that had died. And almost the care home example, they were overwhelmed by how many visits of past relatives that came. So you know, and I think now we've got this sort of national end of life audits, NACEL, as well, which is you know, UK wide, and our programme reflects that as well. So you know, I think we're really in a good place, but it's just extrapolating those real meaningful quality outcomes that you know we could possibly improve on, because those are what make the real difference. Those are what matter to people. Yeah.
Thank you, Sarah. That's really helpful. Tracy, did you want to add to that? Tracy, I don't know if you're on mute or your connection's a bit poor.
You're muted, Tracy.
Okay, sorry about that. I know Brian's on today from CIW and Cheryl from Social Care Wales, and I think we'll start to see that qualitative side coming through with the programme now being aligned to CIW. So when inspectors are going in to inspect, they'll see that difference that the staff are making and hopefully be able to show that evidence. And also with registration and Social Care Wales, we'll be able to see that coming through with the staff being more effective within social care for end-of-life care.
Thank you, Tracy. Teresa, did you want to add to that?
Just thank you. Just briefly to add, how supportive CIW have been to this project. When we started many years ago, they were always very supportive, very keen to understand the programme and to understand what the programme was about. And we did go to see them on quite a few occasions and present the programme to them. So I just needed to thank them really for always being there for us and being here today. So thank you very much.
Thank you, Teresa. Any congratulations or warmth towards regulators is always welcomed from my perspective. So thank you for that. I think we are going to take another video in a few minutes, but we've got time for one more question, I think. And I'm afraid if you look at the panel we had at the start, there's one member who hasn't yet had. I haven't gone to, so she's probably thinking, goodness me, it's bound to be me, and frankly it is. So I'm going to come to you, Julie. I wouldn't want to leave you out. So, you know, I was thinking about, you know, all this work, all this experience you've gained, fantastic. But if you were talking to someone else about the tips or tricks for others who are considering taking on this innovation or this type of innovation, what might they be? It's a big question. It's what people have been grappling with for 200 years, Julia, but you've got 4 minutes.
Thank you, David. As everybody's already alluded to, really, there were lots of positives from undertaking the programme. And I think it also shows how passionate everybody was, considering what the circumstances we were in and the difficulties both clinically and the care homes were encountering, that we did manage to sort of see it through to the end. So I think that just goes to show how much everybody thought of and the importance of carrying this out, really. As everybody's already said, it had a huge bearing on the individual's preferred place of care, that the staff were more confident and aware of their residents changing and the needs to be a little more proactive in arranging and planning their wishes and planning care around that. And sort of the offshoot of that then was that those care home staff were being part of it, they were then empowered to cascade that information and teaching to their colleagues within the care home setting. It also, I think, in some of Teresa's evidence, one of the questions that came up in the chat box was alluded to how GP involvement. And I think some of the evidence that Teresa and Tracy's work has shown is that people that had engaged in the programme were much more able to articulate the views of the patient and their wishes, and able to have a more in-depth and meaningful conversation with the GP than streamlining the quality of care, really. It's also sort of looked at the need to reduce or even perhaps stop inappropriate admissions into the unscheduled care. That has obviously huge implications for the hospital side of things, but also for that of the patient and the family of an distressed ambulant admission into an A&E setting. And that obviously was very important to all aspects of healthcare. The multi-agency working as well has been very important, as Tracy's already mentioned about, and how that sort of increases networking and the ability to have conversations and the confidence to discuss and be an advocate for the residents in their particular settings. It was also very useful and pertinent to have the expertise and the influence of Bevan, which helped increase the network and the coverage and raise the platform, really. Although all this has been very positive and we're all very passionate, there are some sort of more negative aspects to this, in that there will be discussions around funding and capacity of individuals. There is a transient workforce within the care home setting, so that obviously has a bearing on how then we keep tabs on that. And really, I suppose, for health boards and GP clusters and all that, to actually really make this part of their key objectives, because without that, even though you might have the drive from the individual small team, we small fish in a very large pool, and we need to really expand that out to the wider audience. I'm not sure if anybody else would like to add to that, given that Teresa and Sarah have got a little bit more experience, as Lisa and I are the newbies in all of this, but there are definitely more positives than negatives, but I'm not completely adverse to the fact that there are hiccups and potential issues going forward.
Teresa, do you want to come in?
Yes, after obviously living and breathing this project for many, many years, some of the tips I would say are, yes, you do need to get your health board on board with you. We are only small in a big organisation. You need the support of your line manager, and I've been lucky enough to have that, but also you need the support higher up the organisational structure, and that's really important. It's really important to get yourself noticed. To get yourself noticed by the board and take things forward by maybe presenting at study days, maybe taking this to different areas and pushing yourselves forward, really, and putting forward the benefits that this project, the benefits the project has for the individuals in care homes. You know, we're there really, aren't we, just to make sure that their end of life care needs are there for them. But we need to make sure our voices are heard, and that's really important. And sometimes that can be quite difficult. We're lucky in BCU because we have line managers who are very supportive. But you do need the board, the health board, with you on this as well. It's so important.
Thank you, Teresa. And I hope the imprimatur of the Bevan Commission can be really helpful in that as well. You know, it gives some real kudos to the work, and I think that's really helpful. And I have to say, it's really refreshing to have these conversations where we're not talking about people flow or finances or whatever. We're talking about the impact on the people themselves, and that's been a really you know, a really positive bit of interest, I think, over the last couple of questions. I do kind of draw your attention to the chat. That's obviously can add to the conversations. We've obviously had the conversations about primary care and GPs and clusters, etc. So keep an eye on that. It's always very useful. But you'll also be aware, I think, that this project is one of a number of projects that are taking the adopt and spread approach supported by the Bevan Commission, and this is one of a series of lunchtime sessions where those are going to be they are being demonstrated and discussed. And clearly you can attend those sessions, but ones that have already happened, you can see more about them on the Bevan website. But we're going to get a short video now which gives you a little bit more information about that. So I'm going to hand over to our technical expertise to run that video. Thank you. And I strongly recommend you take a look at the website. It's one of those, a bit like a rabbit hole. You start down one road and you don't know where you're going to end up. But you've learned a lot in the process. You may have missed 3 meetings, but at least you've learned a lot about good innovative projects. So I do recommend you taking a look at that. So we're going to kind of expand the discussion that we've been having. We've got about 20 minutes, I think, to do that. I'm not going to pick on anyone here, really. I'm going to kind of go to the whole panel as such, and they can come in. I'm thinking about before you started this work as individuals, before you actually started, and now, and over that period, thinking about high quality care, care homes, domiciliary care. What do you think you've learnt over the project that you didn't know before? What have you taken away in terms of learning? I haven't got someone to come to. I would instinctively go to you, Teresa. Would you mind kind of saying a few words of what you think to that?
What have I learned? I think before I did this project, I learned that it's not easy. It's difficult to take an innovation forward, but that the rewards are just more than ever. I think working together with the teams across Wales has been an enormous pleasure. I've taken such a lot from that. They've been so motivated and enthusiastic to take this forward. I think the other thing I found during the project is, having really a really better insight into the care structure, looking at different care environments, which obviously I've not been part of, to understand our care home functions, to understand how the pressures the staff are under, understanding how difficult it's been for them during this pandemic. These have been really massive differences for me. And that will be the thing I will always take with me, is how hard they work within the care sectors, how they don't always get the appreciation they deserve. And maybe one of the difficulties I found as well is that they are a transient workforce, so they do move a lot from home to home and care setting to care setting, and that is sometimes really difficult. But it's something that we're aware of and that we can support. But yeah, it's just been, for me, throughout the many years of doing this project, I would only say that it's been probably one of the best things I've done within my career. And I would really inspire others to take this forward, because I'm extremely passionate. Even though I have recently retired, I am extremely passionate, and it just makes me feel so good that things are being taken forward and spread across.
Thank you, Teresa, and we're not jealous of your retirement at all. Tracy, would you like to add anything to that?
Yeah, I think for me, previously I've done the residential and nursing home programme of the 6 Steps to Success. And so doing the domiciliary care, I think reflecting back, found how difficulty they find the communication, you know, between primary care, hospitals, the family and the themselves, that they don't always get the full information that they need to be able to deliver that care. And so by being able to support them with a programme and give them the links to that communication and the way that they can strengthen their communication, I think has been really enlightening for me.
Thank you, Tracy. Julia. Hi, Judy, you are on.
What I would just like to add to that really was how when you started in the one particular home we were in, how that little bit of support, encouragement made them want to sort of run with it more, and they started looking at other aspects. That was all involved in the 6 steps. They looked at little other aspects of doing small audits within the home, just to identify and understand all of the care workers' previous experience and knowledge. And it was just like a snowball effect, really. And that really, because I suppose to some it was my experience of going into care homes as a professional, and I was really, really pleased and touched that they're there for the right reasons, obviously, but they really wanted to absorb as much information and knowledge just to make sure that what care they were delivering was the best they possibly could. So that was quite an important part for myself.
Thank you, Julia. Sarah, did you want to come in?
Yes, thank you, David. I mean, just to say thank you, Teresa, for your enthusiasm. You know, she's been awe-inspiring as far as really pushing us with the programme. But what I was always amazed when I first started to deliver the programme was that there is this sort of, I wasn't aware of this divide really between the NHS care and social care, and it's not, you know, it's not intentional, but they're in very different places, and to start to bring in that partnership work in, bringing that equitable and quality care, and everyone aligning their care together, because we're actually looking after all the same people, you know, from from secondary to primary and into social care. They're all our precious community, really, our vulnerable community, and it's really brought everyone together, I feel, and I noticed that lots of the care homes contact me for advice, so it's really really linked us and brought a real network of people and make sure that we share those decisions and bring the multidisciplinary team or interdisciplinary team together, which I didn't feel it. I never realised how fragmented it was actually in the beginning before I started it. So I'm really pleased that it's brought us all together.
Thank you, Sarah. I'm going to kind of stick with you if you don't mind, Sarah. Apologies to kind of put you on the spot a bit. I've heard a lot of mentions of the 6 Steps program, but I presume it's not the only approach that can be taken. And so why 6 Steps and why now? I don't know if you can give us something on that.
Definitely the 6 Steps to Success programme. I've mentioned that there's an established programme, and it's a tried and tested programme, so it's available throughout the UK. And obviously, what Teresa and the team have been able to do is adapt it to Wales as well, because of different quality framework structures. So the Welsh aspect of it has been aligned with the lines of inquiry of the Care Inspectorate Wales, so it reflects those, and it reflects what happens in Wales as well. So it's a very tried and tested programme. It's adaptable, and it's responsive. So again, it's always been updated. We have it's called the Northwest model to assess patients, assess residents and identify residents in their potential last year of life, and that everything is updated, so it's a very real-time responsive programme. And obviously, that through COVID and the pandemic, we've adapted it to online and successfully adapted it. And having adapted it now, it's actually benefited the care homes, because they haven't got to commit that time, especially in Powys, to travel miles to a venue to access training. We can do it online. So again, that time commitments, having adapted the programs, it's been really helpful, especially in this stressful time that the care homes have had to live through. It's a standardised program. And I keep saying it's equitable. It's definitely co-produced, which is the sort of ethos of Bevan as well. And all the time it's reflecting on the learning. We use significant event analysis all the way through to actually reflect and make sure that care experience is a quality experience. Again, we've got our quality measures that reflect national and local policy as well. Supports key Welsh Government documents and CIW Inspectorate, and it's that strong partnership with key service providers that I think it's just excellent. And then we've always got that assurance of that strong partnership with the NHS England team, the 6 Steps team, nationally as well. So it's a programme that we want to see. The vision is spread across Wales, to make sure that all the care homes have that same training, and the training's localised to their needs as well. And the Six Steps champions can take that experience, that qualification to other care homes. So, if they're moving, that they go to a Six Steps care home again. So it's all ever evolving, ever growing.
Thank you, Sarah. That's really interesting. But I'm going to come back to Teresa actually, and I'm afraid I'm going to talk about something that we have tried to avoid, I think, which is resources, because it strikes me that Six Steps is a reasonably resource-intensive program. It's not something you can do in a day. It takes some thought and investment of people and resource. So what makes this different to perhaps other things you could do that might be shorter and cheaper? Why this approach?
Yeah, I would agree that that the program is a long program. It usually takes about 6 to 8 months to go through the program. But I think the difference this program makes shows for itself, really. It's consistent, and obviously, as Sarah said, it's based on best practice guidelines. Changes to practice are embedded in this program. And, if you go on a study day for one day or even slightly longer, there is no way that you'll be able to embed changes into practice. They need this length of time to be able to embed the changes that they're going to make to the individuals in that care home. They do a portfolio of evidence, which is something that they are used to doing within a care home setting or a care environment setting, and that's really important. So it's evidence-based. And we are now beginning again to do face-to-face visits, which are really important as well. And we have annual study days for sustainability. Again, that's important because it's best practice and practice changes. I think, we have end-of-life care champions at the end of the course. And, data has shown that the changes to practice have made huge differences to individuals. And if you want to look at it like that, the individuals will stay then within that care home setting. So we are reducing inappropriate or unscheduled admissions to hospital, therefore saving money. We're also ensuring that they're getting the best end-of-life care as well. But I think for the care homes themselves, it is a commitment. You are right. It is a long period of time, but they do see the need for it and they do see the change. I think the other thing is that care homes have education anyway, not always in end-of-life care, but this care education might not be consistent. It might not be consistent practice. It can be, there could be inappropriate variation. And the training might not always follow the guidelines for palliative and end-of-life care. And it's different in different care homes. So there's been a very inconsistent, I feel, training in end-of-life care. It's not the same across. And this again is cost effective. We do this within our role. They don't pay for this course from the care homes. We deliver this to them free within our role. So they don't need to pay, but they do need, obviously, to send the staff on the course. But if they can see the reasons why, that can sometimes be a challenge, then they are very keen to send their staff. It follows the prudent health principles, doesn't it? Because it's cost effective and efficient, but really you don't need a vast amount of people to spread it across a wide area. And I just think it ensures best clinical practice, and there's evidence of change in practice. And, within BCU, and I must mention my team, because that's so important. I've worked with numerous people over the many years I've been in post, team members who have worked extremely hard to take this forward. And it is a challenge. It is a challenge. But it's made huge differences, and the data.
Thank you, Teresa. Fantastic. Julia, I think you might want to add something to that.
Yeah, only very quickly. in that it's a very pragmatic approach and it covers all aspects. So whereas other teaching programs might concentrate on specifically maybe the last few days of life, this starts at the beginning and identification, looking at preferred discussions around preferred places of care into the last days of life, and beyond then into things like memorials or family support, bereavement. So even though it's quite intense and quite long, it does actually cover all aspects, and there's lots of transferable aspects of the course that can be relevant to all residents.
Thank you, Julia. We're coming towards the end. We have got a little bit of time. I've got a couple of questions here that I'm just going to put, and I want you all to think back to when. Do you remember when you used to get in elevators with strange people those days? And I kind of want to imagine the team has done that, and perhaps you're in the elevator with a manager of a care home. I think I'm going to come to you, Tracy, for this. Okay. So you're speaking to a manager of a care home, and they want to know a little bit about the innovation and why they should consider it. And you've only got the time of the elevator to persuade them. What do you think you might say, Tracy?
I would say that the managers that I've spoken to initially, their eagerness and engagement has been massive. They've wanted, because they can see the benefits to the support of the individuals. I would say that a manager would understand if I spoke about the Social Services and Wellbeing Wales Act and about how they can support the individuals to have a voice and control, and how then this can help them and support them to meet their RISCA framework for when they get inspections. It would show the managers how sustainability within the programme and benefits to the staff. I would also say how it can benefit the staff in retaining staff, because you're supporting them as champions, and then they cascade the training to other team members. However, in Wrexham, we've never had to promote it. We've always had people coming to us and wanting to come on the programme and be on our waiting list. And we've got waiting lists that we could fill courses again and again.
Thank you, Tracy. Thank you. I'm sold. Okay. Okay, you get in the elevator, you've got a manager of a care home or an owner of a care home. That's fine, that's easy. The really horrific one is when you get in the elevator and the chair or chief executive of the health board gets in with you, and you've got to travel 6 floors with them. Now, Julia, Lisa, I don't know. Imagine that's you. What might you be saying to that? We won't name any names here, but imagine it's a chief executive of a health board. What might we say to them to say, look, this is 6 steps to success. I want to tell you about it, and the support you could give us would make such a big difference, and this is why you should. What might you say? I don't know, Julia or Lisa, who wants to pick that up? You're both on mute. Are you both scared? I don't know. I've answered the question.
I would nudge Julia if I was in a lift with her to say you can speak out.
Thanks for that, and I wish we were only going 1 floor, not 6. But really, I suppose the most obvious is the importance that it gives to the patients and their significant others. But also from a chief exec, there will be an element of cost and finance. So it'll be looking at ways of reducing the unnecessary admissions and possibly maybe preventing the need for them at all, which would free up your ambulances. It would look at your patient flow. So all those sort of key elements that somewhere higher up in the board of directors would be looking, because yes, there's obviously, for us as nurses, patient focus is the key, but we're not naive to think there isn't an element of financial implications somewhere along there. but really it's looking at how we can best keep the people in the most appropriate care settings for themselves and their needs, and reduce, being prudent in that aspect, but also reducing some of the potential cost implications of having to transfer patients from their care setting into a acute setting. Is there anything to add? Or
I just say further to that, that by delivering this kind of innovation, we're actually delivering on a palliative end-of-life care plan, Theme 7 for education in care homes to provide an equal level of care regardless of whether a patient or resident is at end of life. So we would be addressing that need as well. I'd also say that once you've got the buy-in, that is really essential. We found that we have somebody designated to deliver the programme in their own right. I've got a full-time role supporting the service. Julia is hospital-based palliative CNS here, and we're lucky that we've had some help from a lot of CNSs around the service to help deliver the programme. But I think it is more beneficial if you've got somebody that's actually, focus is delivering this programme as a whole.
Fantastic. Sarah, did you want to come in?
Yeah, I just wanted to say with the sort of improved outcomes, and if we're talking to the chief executive, that as nurses, we know we're achieving more good deaths for our residents, and that experience translates into sort of less use of bereavement services after death for loved ones. So they're achieving that good death in their preferred place of care and death. Fewer complaints, that can be as far as the care home's concerned, as far as the care structure, and especially around complaints around end of life for relatives and friends. The care homes have an improved reputation as well, and that reflects in the commissioning. There are reduced, as Lisa and Julia said, reduced unplanned hospital admissions, and once you quantify that, it translates into thousands if somebody is admitted, one of our residents is admitted, and sometimes inappropriately admitted when they're actually dying, and that again translates in potential complaints. And we've got a more skilled workforce. We've improved morale, and that gives improved retention as well. So that's. Are we on the floor 6 yet?
I'm going to the penthouse.
Fantastic. Sorry,
David, just quickly as well, obviously raise the profile of the trust or the organisation by trying to attend conferences or get papers published. That also helps just show how innovative practice is within an organisation.
Thank you, Julia. Fantastic. Okay, we're coming to the end of our time, I'm afraid. I mean, how inspirational this has been. Fantastic. I think in many ways this is a great example of the kind of person-centered care that we've been talking about for too long without seeing it happen. But here, this is a real example of it can be done. You can create systems that put people at the center of that. It was remarkable actually when Sarah mentioned it, but I hadn't really thought about health and social care until that time as two separate sectors, and in a sense, this is a program which doesn't seem to matter really. That's not important. What we've got is a seamless approach, and that's fantastic. Of course, it's innovation that isn't brand new. It's innovation about learning and adapting from what others have done, and surely that's got to be a really positive message. But I also think, you know, we talked about the chief executive in the elevator, but actually this isn't one of those schemes that's done by a memo from the chief exec, is it? This is the type of change that's done by people on the, you know, working day to day with people, with patients, etc., coming together and you know, deciding things could be different and deciding to invest their own time and their own capital in that. And so I finally, for me, I think what this has shown me is that innovation is a team event. And, you know, you'd think that the panel today have known each other for 30 years, you know, but they haven't. They've come together with a shared ambition and have grown closer, I'm sure, together over that time, but have really kind of pooled their expertise and ideas to drive this forward. And so what I want to do on your behalf is really thank the panel for today, for the presentation. It can be a bit intimidating, but more importantly for the investment of their time in making this a reality. So, you know, for Lisa, Sarah, Teresa, Julia, and Tracy, a great big thank you for today and for all the work. I also want to thank, while I can, the Bevan Commission, because without them, of course, you know, these kind of stories would not necessarily get told. We wouldn't all be able to learn from each other and build upon that. And finally, I'd like to thank you all for joining us. It's so difficult with all the other pressures we have to take time out to learn about these things. And, you know, today may not lead to anything, but for some of you, and I've seen this in the chat, this may be the start of thinking about this, thinking about these challenges, and thinking about investing some of your time in taking forward work like this. Thank you all for your time. We're going to end with a little video. And I hope to see you all at the next showcase. Thank you very much indeed. Goodbye.